I would like to move on to Laura Cornelissen. We heard already that the ecosystem at the moment, although we work together, there is still fragmentation in Europe, unfortunately. It's very difficult to keep the public health organizations engaged in the community and to work with vaccine manufacturers, for example, or to have a communication. This is what we witness. We have multiple initiatives and ecosystems such as ID Drive, which is also an IMI follow-up initiative, but we also have the VBIS platform led by ECDC that is doing vaccine effectiveness. And we have VAC4EU and probably many more, but it's still not completely connected. Now, I'm very happy that Laura is here. She is from Sciensano. She's a medical doctor working at Sciensano, who is a VAC4EU member, as well as RVM. But she is not just working at Sciensano, she is also a NITEC member in Belgium, and she is the representative of Belgium at ECDC. So we would really like to hear your perspective, Laura.
Thank you very much for this kind introduction and this kind invitation. I do feel a bit intimidated here, not just because I have never done an IMI project, which seems to be rare, but also because I was asked to give the public health perspective. And I think it's a pretty daunting task, and I'm not sure that there's one public health perspective, let alone that I can represent it. But what I can do is talk to you about the experience and the perspective from the Belgian Public Health Institute, which is where I work. So what do we want? I think when in our daily work, we don't do that much vaccine safety monitoring, because that's Jean-Michel and his colleagues at our medicines agency, but we really want data on vaccination coverage. And we had this beautiful example during COVID, where we had this dashboard and you could follow it in real time. It was super exciting. You could like pick the bar you wanted to root for and then see how the green processed. We also had the data linked to contact tracing, so we could do effectiveness studies, not just on severe disease, but also on the risk of transmission. But that was COVID. And we learned that we want local data, because as much as we are globalized currently, policymakers, and especially politicians, seem to be much better convinced by data that this Belgian EU will do, but preferably it's really data from Belgium itself. And that might maybe sound a little bit provincial or stupid, but I think there are also good reasons for it, because health systems do differ, demographics differ, populations differ, there's different genetics. So it's fair enough, I guess, to want really local data. We want data that is independent. And when I put this on the slide, I really didn't think twice about it. It seemed obvious to me. But now that I've heard all the other speakers saying how important public-private partnerships are, I realize how much this is treading on thin ice. Yet I stand by the point, because as much as we do need collaboration, I think we cannot deny what is happening in, for instance, the US, and how perceived conflicts of interest were quoted as the reason to oust half of ACIP members. And so this is not necessarily me saying that we need independent data. It's the European Commission that really established a platform specifically to do industry-independent studies. And I think we need collaborations, but at least in terms of perception and in the current climate, it might also be really important to have some independent studies and estimates coming out. Timely data, for sure. I think most of the speakers have said it. Peter alluded to it in his introduction. I think there's a debate on what is timely data. I showed you the COVID dashboard earlier. When we tried stopping to update it on weekends after like 1.5 years of pandemic, when we were really quite tired of working weekends, because although it's mostly automated, someone needs to manually check it. We faced a lot of backlash. We really had to defend our point that it was not useful to update it on the weekends. No big decisions were going to be taken, and no big changes were going to appear anyhow. But it seems that once people are hooked on real-time data, it's hard to convince them of anything else. And so, as much as I agree on timely data, not everything needs to be real-time. So we can have a discussion on what timely actually means. Of course, it needs to be high quality. That seems obvious, but it's not so easy. We know that primary care data, healthcare, I mean, I was a clinician. When we write our notes, we don't do it for national statistics to be extracted from it. We do it for ourselves and for our colleagues who need to look after this patient next. So there's a lot of work there to be done, which for sure all the VAC4EU members know very well. And it's about the data even being available. When we wanted to look at coverage in healthcare workers, we realized we actually don't have a source for this, because the only thing we could find was all the people that had a diploma that were aggregated to work as a healthcare worker. Now, I'm a gynecologist by training, so my vaccination coverage, vaccination status went into the coverage estimate of gynecologists, whereas I haven't seen a patient in the past 6 years, so it was probably not my coverage they really wanted to know. It needs to be detailed data. You can have vaccine coverage estimates, and then they go, yeah, sure, but what's the vaccine coverage in people with risk factors? And it becomes a whole other debate and task to tease out these subgroups. So how can we do it? This is how we did it during COVID. For the first time, we had a national vaccination registry. It was compulsory for the vaccines to be registered there, which was easy to do because the only way you could get vaccines was through the central procurement of the government. So it was easy to link it with an obligation to register it. This is currently not the case. You might also know that Belgium has quite a complex political structure. And so, although I think everyone was pretty convinced of how well this worked, it was then decided that actually vaccination is a regional competency, so we're not going to have one national registry, but we will have 3 separate, and then we can start talking about how to integrate it, etc. So currently, yeah, we're at this stage of trying to, or not we, the different governments are trying to roll out the different registries, and I'm being told that the integration of the data to get national data would be for 2028, which seems incredibly far away still. For COVID, which we don't have for other diseases, we had really good lab testing. Well, we had comprehensive monitoring of the lab testing results, etc. So we could do a lot of linkages, and then we periodically linked it with additional sources that were less timely. Reimbursement data is typically complete after 2 or 3 years, because you can still submit your claims after even 2 or 3 years. So, how do we get there? Local data, that's clear enough. We need to use Belgian data sources, but then we need to make sure that they're there. I mentioned the example of the vaccine registries, but it even goes beyond that. In Brussels, where you're currently sitting, it's only in the past few months that the well baby clinics, which are one of the primary vaccinators, that they actually have computers. Previously, they would still write down the vaccinations in the paper records, and they would put stickers on another paper to reorder and refill their stocks. So I'm really happy to say that this is now in the past, but again, it was a big challenge to convince the nurses who've always been working in this in these well baby clinics to actually change. And in the south of Belgium, there is even some spots where there's no, where there wasn't any 4G network, and so the software ran into issues in the offline mode, etc. So yeah, we're not there yet. If we want independent data, then we need to have sufficient funding. There is, as I mentioned, the VMP, Vaccine Monitoring Platform initiative that received quite a lot of funding from the European Commission, and there's a lot of, as of now, ECDC again issued a tender. I think post-COVID, for those working in public health institutes, it's been a bit easier to secure sufficient funding because the need for strong surveillance suddenly had been proven quite clearly. If we want timely data, it really needs to be automated data extraction, otherwise we won't get there. But again, there's challenges there. We need to have the primary databases, and if we want to have sufficient detail, then we will only be able to get that through linkage. But this linkage, again, comes with lots of issues. One side is the technical part, where there's different technical standards, and FHIR and CMER, and different technical specifications. But the big issue is really about privacy and GDPR. And I actually had to step out of this meeting during lunchtime because we're doing a risk assessment on Mpox. There's Clade 1b in Europe, as you might have heard. And I was arguing for better registration of the vaccinations because we had quite a big campaign in 2022. And this was actually met with a lot of criticism by all the clinicians on the call, who were like, no, 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 we want anonymous vaccination because Mpox is it's an STI and it tells something about your sexual behavior because it mostly affects MSMs. So if we're going to register this, then it really has issues for, it could stigmatize people, etc. So yeah, I think from our perspective, we obviously all want the data and we want it linked as well, as much as possible, etc. But I don't think that everyone is as convinced of the need of that and of on how to get there. Flanders just recently updated their legal framework, so they would be allowed to link their vaccination registry to other data sources. And they had quite a hard time getting it through Parliament. There was a lot of criticism on it, and they were really not so happy. They managed to get it through, but it was harder than expected. And this, of course, is also linked to the vaccine certificates that we had during COVID and all the adverse sentiments that caused. As I said, linkage is really important. I think everyone recognizes that. But if I see in my daily work how hard it is, I really think we have still a long way to go. And I was quite happy to see that this is not just my personal feeling and me not knowing how to navigate the system, but something that also the OECD flagged. Where they, I think, quite rightly said that there's a lot of potential, but a lot of work still to be done. And with that with all of that in mind, of course, there's the European health data space that is looming around the corner, and they really push for this secondary use of data. And probably most of you know more about it than I do. I just stole this slide from a webinar. But if you look at what they want, the user journey, it's great. Like, you want to have, it's all kinds of data. It's electronic health records, reimbursement data, biobanks, but even socioeconomic determinants. So it applies to really across the spectrum, which I think as a researcher we can only be happy about. There's one central application. Then they say, okay, it comes at a cost. You need to pay for cost. And I think there it already starts to get really complicated, because what does it mean to pay for cost? I showed you that we had really nice surveillance for COVID-19 vaccines. And so we were, of course, also solicited solicited by pharmaceutical companies, because we were putting out vaccine effectiveness estimates, but not brand-specific. And so they applied to us and were like, okay, we want brand-specific estimates and we want all kinds of data. And since we had a procedure in place that allowed other researchers to ask access to data, we also needed to have this for the pharmaceutical companies. We really didn't have any arguments to refuse them. But it does raise questions, because at our Public Health Institute, we also have the OMCL, which is the National Control Laboratory that independently tests each batch of vaccines before it's released onto the market. And so they, for instance, they are really, really reluctant to, they are also Sciensano. And so if Sciensano is paid by vaccine manufacturers, it kind of puts them potentially in a difficult situation. Of course, it doesn't really, but again, it's a lot about perspective and narratives. So it was decided, okay, we have them pay for cost, so not for setting up the system, etc., but really just for the extra time it takes to prepare those pseudonymized data sets so that they can do the analysis. And so our colleagues were filling in timesheets so that they knew how much to charge the pharmaceutical companies. But even there's an opportunity cost, because this was COVID times. I mean, you remember, everyone was super busy. We had probably other research questions that we wanted to investigate first that were not about brand-specific vaccine effectiveness, because anyhow, you didn't have a free choice in Belgium. And even though we were paid for this work to be done, that doesn't immediately translate in additional manpower. Like, you need time, you're not going to recruit another person immediately, and especially not if it's like maybe a week time. So pay for cost might sound simple. I really don't think that it is that simple in reality. And I think my baseline is that the European health data space is coming. I honestly think it's going to be marvelous, but the timeline is pretty ambitious. It's been officially approved, so implementation is going to start soon. And from my perspective, in any case, there is currently a very big gap between what needs to be and what currently is. And I'm not so sure how we will actually be able to bridge that gap. Thank you very much.